Welcome everyone. We will be recording the session today and it will be available on our website post event as well. I'm Zoe Fry, one of the directors of the OS and working with the Vivaldi social care team to onboard care homes. We've had a few apologies this time actually, which we'll note in the notes post event. We won't go through those now. If you do want to join in the conversation, please use the hands up facility or the chat facility. It's very informal, so please do come in. If you do put your hand up, if you can just say who you are and where you come from, that would be wonderful. Thank you. So first of all, do we have any matters arising at all, please? No, fantastic. And are there any questions on the action points at this stage? That's brilliant. So without further ado, I'm going to hand over for the project update, and I think we'll start off with Laura, please. Thanks, Laura.
Yeah, hi everyone. Good to see people. So we're making good progress. The data is flowing. Oliver will tell you a bit more about that in a minute. And yeah, I mean the headline message is it is working. We're still working towards the numbers that we want to see. And I think unless Mike tells me otherwise, we're still waiting for PCS to come online. But the other two software vendors are supplying us with data. Our research team are starting to do some analyses on those, so we're hoping to have some outputs from that around February, and hopefully you have all seen the report that's been drafted. So maybe I'll hand over to Oliver, and then Zoe, I'll maybe talk about the programme grant a bit later. Okay, thanks.
Thank you, Laura. So I don't have too much to update in the way of the data set itself, in that we haven't had a new data extract through to UCL from NHS England since the previous one of these meetings. So the next data extract is due in 2 days' time. So I'll then be able to review how many more homes have gone live, and check through how much more data we've got on the outcomes as well. So yeah, as has been mentioned, the report, the initial report that you've seen, we are planning to circulate more widely in the near future, in the next 1 to 2 weeks. So it'll be exciting to get kind of broader feedback on that. Beyond that, there's kind of a few other points I could update on. So we're still progressing with planning kind of in-depth analyses, focusing at the moment on urinary tract infections and skin and soft tissue infections, given the priorities of care homes and the data that we currently have access to. So one point relating to that is that we realized it would be really useful to be able to use the prescriptions data that we have to help give us a fuller picture of the comorbidities of individuals within the cohort. So within our current ethics and CAG approval, and within the current patient-facing or participant-facing information that we've got as well, we state that we'll only be using antimicrobial prescriptions data. But there is actually a full data set of prescriptions, primary care prescriptions data available through NHS England. So we're planning to put in a request to our paperwork to be able to use those prescriptions data to more accurately describe the comorbidities of people when we're running these analyses. So that means things like being able to use prescriptions for catheters to be able to accurately identify who has a catheter and who doesn't when we're coming to trying to analyze risk factors and outcomes for urinary tract infections. And there are also things that are very relevant to looking at skin and soft tissue infections. So for example, we'd be able to look at diabetes medication and be able to look at that as a risk factor for skin and soft tissue outcomes and for the ultimate outcomes related to those. So at the moment within the paperwork, it says that we will use hospital admissions data to describe these comorbidities, these conditions that might impact on the infections that we're interested in. But at the moment, it doesn't say that we'll also use the prescriptions data to do that. So we're hoping to be able to put that through in order to help really fully inform these research projects that we've started. If anyone does have any comments on queries on that, while we're in the stage of developing our kind of requested update, that would be useful. Zoe.
Yeah, just thanks, Oliver. Just out of interest, how long does that process take? Because obviously we were involved with the first CAG application. So how long will that process take in relation to the project?
So yeah, hopefully a lot more quickly than the initial application. So we're hoping we'll be able to put these through as minor amendments, which then require a lighter touch review and an approval process. So we're hoping to then be able to get it through in time for actually writing these papers within the coming months. Laura, do you want to come in there with any more comments?
Yeah, thanks. I think it would be really good to hear from this group if anybody feels uncomfortable about that. So just to sort of reiterate, so what we said we would originally do is we would use data from hospitals to understand what conditions residents had. So do they have diabetes? Do they have heart disease? Those kind of things. And we can get some ideas about that from whether they've been admitted to hospital for those things and it's in their hospital records as coded data. So we have permission to do that. We've talked about doing that before, and that's a really important thing for us to do. But what we've learned is that there's also data in the prescriptions data set that we have that could be really valuable for us. And so what we're saying is we're not trying to change what we said we do. We're just asking, does anybody mind if we use the hospital data and the prescriptions data to understand the conditions that residents have? And we think that that will really improve the quality of the work that we can put out. But we obviously are keen to make sure that everybody in this group feels comfortable with that. Importantly, what we're not doing is we said we'd measure infections. We've not done now shifting the goalposts and actually measuring different things. We're still measuring infections. It's just about how we understand the people who have those infections. So I hope that made sense as well. Thanks. Judy's got her hand up. Please, Judy.
Yes. Sorry, I had to undo my mic. I'll tell you what it is. We have a great number of urinary infections, and I'm not certain that when you get into hospital, all other medication that you're taking is taken into consideration. Very often, our policy seems to be to send you to hospital at the slightest possibility of a urine infection, although most of us as residents would prefer to stay at home to have and all of that would come up best in prescriptions that we give by our GPs rather than the prescriptions, the infection that comes from the hospital. Does that make sense?
It makes total sense. And Judy, you've hit the nail on the head, and you've basically just explained why we're asking to do what we want to do. So that's exactly what we want to do. So the prescriptions don't come from the hospital, they come from the community. So that's exactly what we want to do. Yeah.
Good, because there is no doubt that if we can sort out how we all get urinary infections and how we can avoid going to hospital,
yeah,
that would be an enormous move forward.
It really would. It really would. I might quote you in our programme grant that's going in, because that is literally the main thing we're trying to do in that programme grant. So yeah, we are fully in agreement on that.
Thank you.
Can I just ask another question again? I'll come over to you then, Francesco. This is pulling in lots of different information. So if we look at the initial report that Oliver presented last month, and we looked at the percentage of UTIs and the percentage of skin infections. So we're looking at the data because we've got the evidence that those percentages are high. And also when we have our care home visits, actually, as Judy rightly said, a lot of people are saying to us, you know, we want to look into urinary tract infections. So that's why you've now decided that it will be really useful to look at the prescription data. So it's just tying all that together so that when we talk to providers, this is the route and this is why we're making these decisions. Does that make sense?
Yeah, I think so, Zoe. I think it's really just recognising that there's actually more useful data than we realised in the prescription. So we always said we were going to look at prescriptions for urinary tract infections. We're doing that. There's other information that's in there, like Oliver said, like things like people, whether they have catheters or not, their diabetes medication. These are all things that are really useful to understand why people are getting urine infections or why they're not. And it's there, and we could use it, but we didn't ask for permission at the beginning. And we think it makes sense to, but we just wanted to check in with this group to make sure that everyone's happy with what we're proposing.
Yeah, that's wonderful. Thank you. Francesco, over to you, please.
Yeah, Oliver, what you mentioned about looking at people's prescriptions, the bit I don't necessarily understand regarding anonymisation, will this be partial, minimal, full anonymisation? Because there'd be certain information that you do want in terms of identifiers. So in terms of going back for approval, what is it that you'll be asking?
So there wouldn't be any change to kind of that level of identification that we're getting, in that the data that are getting transferred from NHS England through to UCL, they are person level, so we can link individual people's prescription records to the hospitalization records, but there aren't any there's no directly identifiable information. So we don't have exact dates of birth, we don't have, you know, names or any kind of personal details like that.
You don't have names, you don't have postcodes, addresses.
Well, we have the location codes for the care homes, so we do know where the care homes are, but we don't have identifiable information beyond that. And then that person level data is locked within this UCL secure system, which only, you know, a handful of people have access to. So it's only kind of 4 or 5 people at present have got access to the data set at that level, and then anything being reported will be at a much higher level, where, you know, we're not giving information on the kind of person level. It's just that kind of higher level summaries.
Thank you. That answers my question. Cheers.
Thank you, Francesco. And Diane.
Yeah, hi everyone. Yeah, I just, when it comes to UTIs, I do have concerns behind the other causes that are causing the UTIs. And talking from my own personal experience, when my mother-in-law went into care, she had advanced dementia, so she didn't have capacity. And fortunately, we were with her one day, we were out in the garden, and one of the carers came and we said, oh, she wants to go to the toilet. And she said, just like that, it's all right, Jean, just do it in your pad. And we were like, no, she needs to go to the toilet. She could at least tell us that much. We want her to be able to, you know, be still empowered to be able to go to the toilet when she can. And it just struck me that, I know there's other reasons behind it as well, like dehydration, and but how many people is that happening to when their relatives aren't there? Because it's easier, just do it in your, and that will cause a UTI. And I just don't know if we delve deep enough into that. And the other thing, and this comes up a lot on our Facebook page, is the lack of incontinence pads that people get access to. I know there is a limit on them, and I'm sure that must be, you know, if they're not being changed regularly, surely that must lead to causing a UTI as well. And then the third thing, which I know I've said before, is dehydration, because we all know that they are often just not getting the hydration that they need. So I think it's great that we're doing research into UTIs, but apart from the obvious, are we delving deeper into what's causing that? I'm not sure whether that's even possible to do that, because there wouldn't be any record of that, would there? But that was just from my experience. I thought, people who've not got capacity, how often is this happening? And I imagine it's quite a lot.
Thanks, Diane. And first of all, I'm really sorry to hear that. And, for me, and I think seeing other people's faces on the call, that is not acceptable, and that is very poor standards of care. So yeah, I'm very sorry to hear that. I'm not sure how we look into that, but Laura's going to come in a minute. I wonder if before we come over to Laura, whether we look into maybe pads as part of the hydration project, and maybe an intervention, because for people on the call who don't know, people who have got nursing needs, residential needs, are entitled to incontinence products, but you're only entitled to a certain amount over a 24-hour period that are prescribed. So that's what Diane's referring to. Laura, do you want to come in there? Sorry, Judy, we will come to you, but Laura, please come in.
Yeah, thanks, Diane. So I think part of what is coming up here is recognising the limitations of what we can do with our current project. So current project is about routine data, but that is why we're trying to move on to the next phase of this project, which is about doing clinical trials and more complex studies. So in the trial, the programme grant that we're trying to get funding for at the moment, one of the key project is hydration to prevent UTIs. So the third one on your list, we are actively trying to address that. In terms of some of the other challenges you mentioned about pads and things, there may be opportunities for us to include capturing some information on that as part of that project. But I think what you're highlighting is there are so many different questions that need to be answered in this setting. And really what we need is the ability to have lots of studies to answer all these different kinds of questions. And so I think that is what the direction we are really trying really hard to go in. But with research, very often you sort of have to tackle these things one at a time. And we don't need to be that restricted. I think we need to be better than that. I think that it's too slow to do everything. We can't take 5 years to answer your first question and 5 years to answer your second. But I think that it is recognising that we are going from what we're doing now, which is very much in the background capturing data, to saying, actually, these really matter as questions. How can we design studies to get the answers to them? But recognising that's going to be more work for the care homes too, because you can't answer these kinds of questions just from the data that sits in the system.
I think as well, sorry, I'll just say this last thing, but I know it was poor standard of care, but there were no malice behind it, because the care home that she was in was good and actually provided a good standard of care, but clearly the carers had not been trained, to do that. It was just easier for them. Unfortunately, we were there, but it did just make me wonder how many other incidents like that. I imagine it happens quite a lot. So I think it's something but I appreciate what you're saying. Rome weren't built in a day and you can't tackle everything at once. But, I just think sometimes you need to look a bit deeper as to what the causes of the UTIs are. And I'll shut up now. Sorry.
Thanks, Diane. And I think you raise a really good point around training there, actually. So how are people being trained? Judy, apologies, back across to you, please.
Well, actually, what I want to say, and sorry, and I have to say, I'm up twice in your pictures, and that's why I have an echo. I don't know whether I have an echo to you, but anyway, the point that I wanted to make is much the same sort of thing in the amount of work that can be done in the reasons why we get these. And I, for example, have full capacity, but I'm still incontinent. So I am reliant on either pads or what's his name? I can't remember. but in it, I am reliant on something. And the other thing that I find very annoying is that the current practice is to say that you can only rely on a laboratory test for urine infections. And that takes about 3 days if you're in a care home, by which time your urine infections got worse and worse, and you're nearly being sectioned.
Actually, guidelines have changed now. So if you've got symptoms of urine infection, a GP can actually start treatment.
I didn't see where.
Sorry.
I couldn't see who's. So no, that's great. Please come in, but I can't see who's speaking.
Yeah, sorry.
It's me.
So the guidelines have changed at the moment now. So as long as you've got symptoms, you don't need to wait them 3 days. The GP can actually start you on treatment for UTI with your signs and symptoms.
I know Judy's shaking her head, and I think yeah.
You don't always have symptoms.
No, I agree, but obviously you got. What I'm saying is, a GP can actually start you on treatment if you've got signs or symptoms.
If you've got
of a urine infection.
If you've got obvious symptoms, yes, I agree. But I didn't have any obvious symptoms. I just had a slight temperature. Nothing else.
They're not, obviously the GP's got to check that, hasn't he? And they're not mind readers, are they? At the end of the day, they're not magicians or anything. So
I mean, a doctor did come in the middle of the night. Luckily, he turned up at 3 o'clock in the morning because I refused to go into hospital, and he said, "I think you've got a urinary infection," and he gave me antibiotics.
I think it's such a I think it's such a complex topic.
Extremely.
Yeah, and it's also dependent on lots of different variables. Sarah, I understand what you're saying. It's also when we've gone out to care home visits, some care homes might work with 8 different GP practices, for example, and GP practices are really variable in what they do. I don't know, Mike want to come in there, but I think there are lots of different variables as to what is prescribed, who will prescribe, and at what stage for each care home. Oliver, did you want to come in there?
Thank you. Yeah, I just wanted to make the point. So we know that the first research report we're going to put out or put together on this isn't going to be perfect, but what we are aiming to do is to kind of accurately describe the scale of the impact of UTIs, so that we've got kind of hard data on that, rather than it, everyone can say that by anecdote, but it really helps having the quantifiable, how many people are getting admitted to hospital a year, what are the outcomes after people go to hospital, what's the usage of antibiotics. We'll also be able to look at risk factors such as people having a dementia diagnosis and how that might be linked to the risk of having UTI, and what happens once that's diagnosed. So that really is a kind of a first step in giving us a solid evidence base about what is happening, what the current impact is. But yeah, we're aware that it's not going to be possible to kind of dig into all of the potential causes or all of the potential things that could be improved. But what we should also have is a measure of the kind of variation in impacts between homes, so we can start to try and unpick whether certain homes seem to be having a higher impact than others. And that obviously then gives a route into trying to work out, well, what we could then potentially explore why things are going well in some homes and not in others. Although that process does take time, but that is what we're aiming for ultimately.
Thanks, Oliver. And I think it hits home to me that actually these conversations that we're having, to be able to achieve having this linked data and be at this stage now is absolutely huge. Laura, do come in.
Yeah, thanks. I mean, Judy, you're You're completely spot on. So one of the big problems we've got is our diagnostics for urinary tract infection are rubbish. This is a well-known problem. There's been massive amounts of money invested in trying to solve it. The good news, it's not going to solve it quickly, is that NHS England have already said to us, could they partner with us down the line to test out UTI diagnostics through what we're setting up. So these are exactly the kinds of problems we really want to try and support getting a solution to, because there are so many challenges around diagnosing urinary tract infections in people in care homes for reasons that we could talk about for about 3 hours. It's really difficult. We need a good test. We haven't got one, and that's something we maybe could help to solve through all of this work.
Fantastic. Thanks, Laura. Mike, can I ask you to come in and give us any updates around the data and exactly where we are with the digital suppliers? And thank you, Mike.
Yeah, of course. And just to touch on the kind of just finish my bit on that. Obviously working GP practice at the moment, and it can be difficult. It's not just whether they have more than one GP practice, but it's the different people within the practice. You know, a lot of GP practices are working on locums quite a lot of the time now, and different people have different rule sets, so it can be tricky. There is something called the Enhanced Healthcare and Health in Care Homes work stream that should be trying to put one care home to one GP practice. That's the kind of idea behind that, is that they just have one GP practice, but it does still exist where there are more than one GP practice out there providing for care homes. So yeah, it's a really complicated thing. Okay, digital supplies. Let's go on to my bit. So Camascope and Nourish are still doing well. As Oliver said, numbers are kind of trickling up now from those two suppliers. We've got one of the larger chains coming on board with Camascope, starting to trickle up again. It's a larger organization, so they're kind of doing it in-house and at their own pace, but we're helping them all the way. And yeah, Nourish are brilliant. We were in another meeting, myself and Lucy, this morning, training another organisation who are with Nourish, who will probably go live within the next week or two. So that's fab, and we've got some others that are also wanting to join. So there's still a lot of interest in joining this study, and we are bespokely catering for their needs, myself and Lucy, essentially. So we're just kind of guiding them through the process and helping them sign up, really. Come to PCS, the last of the 3 digital suppliers, and they are this close to being through the testing phase with NHS England. We've got them through the mesh bit. I think the last time I updated, I said that they'd managed to sort out their sort of mail system on their desktop, and now they're just testing whether they can send the emails or not, and they're getting a couple of error messages back when they send the emails at the moment. So that's what's happening with NHS England currently. Once we've ironed out those error messages when they send the emails into NHS England, we will go live with our first care home with those guys. They are all ready to go. They've already done the additional consenting for their residents, so that they know that they're part of the first home to go live. So there could be some issues with that. It might be a bit glitchy, and if there are no opt-outs, which we need to liaise with them about, if there are no actual opt-outs, then we'll need one resident to volunteer to opt out, to test the opt-out string in the go live phase for a few days. So that's essentially where we are with PCS. With the back and forth that's going on at the moment with NHS England and the design team at PCS, I can't see that lasting more than a week or so before we're ready to go live with that first home. Once we've done that and we're relatively happy with what's happened there, as I say, particularly if they've already got an opt-out, we'll be able to test everything all at once. Once we're happy with that, then the word will be spread quickly and far and wide to all places, and all other PCS providers can go live at that point, which is really very exciting. I was hoping by mid-November that would happen, and I'm still sort of hoping by mid-November that would happen, but I suppose it depends how we define mid-November. So yeah, probably mid to end of November is when we're looking. Thank you.
That's brilliant. Thanks, Mike, and thanks for all you're doing to progress with the digital suppliers. It's excellent. Thank you. And Graham, can I ask you to come in now for an update on the dashboards, please?
Yep, sure. Thanks, Zoe. So I think the last time I updated on this, we were talking about having the data being fed through to care homes on something called the UKHSA non-public dashboard. Unfortunately, there's been lots of delays with the development of that. So we made the decision, engaging with others, to flip over to use Power BI, which we can deliver a lot quicker. So Power BI is like an application of Microsoft in the same ways as Word or Excel is, but it doesn't come as standard in an Office package. So one of the things I know that Mike has written out on our behalf to the care homes engaged in Vivaldi is to identify what care homes or care home chains have Power BI currently. So for those that don't have it, we can actually try to work on a workaround so we can get the data still to those care homes. Probably the other key thing that we're doing at the moment is obviously it's the onboarding of the team, which are contractors who are coming in to develop the dashboard. The last update I had is that it was imminent for them to be coming in. So one of the other things that we are going to be seeking is from each care home or care home group is a user's name. So one person who could be a contact who would be using the data for that team to engage with, so we can get some user engagement kind of research feeding into how the dashboard is developed.
That's brilliant. Thank you. Any questions for Graham at all? Or Mike, indeed? No. Brilliant. Can I ask Lucy? Lucy, did you just want to give a very brief update on the awards? And I'll post the link in the chat facility too, because I think that was after our last meeting.
Yeah, absolutely. So you're all aware that we were going to the awards, and I can't even remember the name of the awards now. It seems like forever ago. Excellent in social care research. So we nominated a nurse from the team, and nominated a couple of nurses from the team who actually made it through to finalists, which was absolutely incredible. It's the first time this award has been given out as well. So very, very proud that the people from our team were there celebrating nurses in this area for the first time. Leanne, who I don't know if she's not with us today on the call, but she actually won the award. So it was fantastic night celebrating with everyone.
Fantastic. Thanks, Lucy. And I'm going to come back across to Laura now to talk about the programme grant, please. I'm aware of time, so thanks, Laura.
No, that's okay. Yeah, thanks. So this will be a bit whistle stop. So I think everybody, we've talked about this at length. So we have this big programme grant that we're putting into NIHR. So it's a two-stage process. We're through stage 1. Stage 2 is due on the 3rd of December. It's all about trying to go from where we are in Vivaldi now to being able to do more complicated studies. So thinking about all the challenges that are preventing us from doing that, trying to overcome them by magic, and developing a protocol, so like a plan for how we could do lots of different clinical trials in care homes, and then testing it out to evaluate hydration intervention. So exactly as you said, Diane, hydration to prevent UTIs. And then with loads of learning and training for care home staff and thinking about how we use data better. And so there's a lot in there. It's probably going to be somewhere between £4 and £5 million over about 5 years. So I'm not going to go into any details on that because we haven't got time. But what I did want to ask you about is throughout this programme, in the way that we've got this Adult Social Care Engagement Collective, we need to have sustained input from people like all of you throughout that grant. And so what I'm proposing is that we would get a group of maybe 6 people, like a subset from this group, to feed into that group, and that they would work closely with us throughout the programme and feed into all of the different elements of that project. So the kinds of things would be, we'll have a programme steering group. We would really like 2 people from this group to sit on that programme steering group and sort of oversee the whole thing. But we also will be asking for sort of more day-to-day input. So things like when we're saying we want to talk to residents, relatives, staff about data in care homes, could members of this group work with us to help us think about how we explain that in a way that makes sense? So there are lots of different ways in which we would really value input from this group, but we need a structured approach to make it work. I haven't told you this, Zoe, but in the grant, I've nominated you as the person to sort of oversee that group of 6. We provide some training. You can say no, and also thinking about how we would say thank you. So people would be paid for their time, but also inviting people to take part in events. We just heard about this awards ceremony. I was thinking that was something we could do. So this is all a bit work in progress ahead of the deadline, but I really just wanted to put that out there and see if anybody felt very strongly that that doesn't sound like the right way to go, or if there's anything else we should be doing. That I'll stop there. I saw you laughing.
That's brilliant. Thanks, Laura. Francesco, did you want to come in there?
Yeah, just to ask Laura, obviously you haven't got that much time before the 3rd of December. With that amount of time and that kind of grant of 5 million, sounds to me like programme grant for applied research.
Yeah, it is.
But we're just doing one now where we've been fast tracked, but when you're given your expression of interest, you've got 3 weeks to put in your full application, so you've got a bit more time. What I'd ask you, what I tend to focus on is things around plain English summary and the way patient, carers, public are actually going to be involved, looking at the work packages or domain and ensuring that, you know, there is the narrative and perspective of the lived experience within the work packages, which is comparatively new for some researchers to, you know, manage and understand. So I guess the question for you is, have you identified someone who's actually leading on, you know, the patient public involvement and engagement?
Yes, so that would be Zoe and Kate as part of our grant team. So they're co-investigators on the grant. And exactly as you say, so we need to have that sort of spirit of engagement, involvement throughout the grant, which I very much hope we do. But then also we need discrete tasks. So in each of the work packages, we've identified areas where we think involvement of PPIE members would be particularly valuable. And so all of this is being written at the moment, and Zoe and Kate are going to get an email this afternoon. And so to see whether you think what's there makes sense. But yes, thanks, Francesco. That's exactly the model that we're adopting.
Okay, so obviously you're in the right ballpark, but you have got lay public contributor co-applicants on your grant application, yeah?
Kate, yeah, Kate is a lay member, yeah.
Right, thank you. Okay.
Thanks, Francesco. I don't know whether you wanted to come in, Kate. So outside of this meeting, Kate's been heavily involved in care home visits and programme grant meetings. Kate, I don't know whether you want to come in there.
Yeah, sure. So, well, we've got a very important care home visit tomorrow, which we're all very much looking forward to. And yeah, I go along as part of the team. My mum was in a care home for 8.5 years. I cared for her for nearly 15, and so I go along as the lay person basically. And I've joined Laura and Zoe and the rest of the team at various of the grant meetings, again to, you know, I'm there. I don't understand the long terms and whatever, so I make sure, or do my best to make sure it's put into lay terms, and I'm there sort of to try and help represent the group. But obviously, yes, I think it's always important.
Thank you.
I'm looking forward to the visit tomorrow. It'll be really exciting.
Absolutely. We've got a visit tomorrow where we've got literally about 20 guests coming along, including Lucy Chappell, Gail Mazzetti, CQC, representatives from NIHR. It's going to be a fantastic visit. Thank you very much.
And also the guest star of our podcast.
Absolutely, absolutely.
That's the person I'm most looking forward to.
Yeah.
Okay.
Of course you didn't meet him. Yes, our host, the registered manager of the care home, which will be fantastic. also just on involvement from Kate when we go out on care visits, we've recently been gathering the evidence for the annual CAG review, and that included asking us about numbers of residents, relatives that are on things like the Adult Social Care Engagement Collective. And we think going forward, what's going to be really important, because it's not just people who attend these meetings, there's a lot of engagement when we go out on the visits. So we're going to be giving Kate a section on the agenda to be able to feed that back to this group, so that we can feed in that evidence as well, because we gain a lot of knowledge, we get a lot of questions asked. Kate, I know that we've talked about it briefly, but
Yeah.
are you happy to do that going forward?
Yeah. No, I mean, well, at the last visit we had up in, oh, my brain's gone blank. Sorry, too much else on. Yeah, I mean, to spend half an hour speaking to a lot of the residents, or 3 or 4 of them, really good engagement. And yeah, just take away questions from that, be able to feed those questions back, and also stir the different sort of questions that we get. So it just, every time, it just helps evolve what we do. But yeah, very happy.
Fantastic. Thanks so much, Kate. And I'm very aware of the time. So in terms of events, I think one of the most important ones, and we're hoping that a lot of our Adult Social Care Engagement Collective are going to come along, is the 9th of December, Lucy. I don't know whether we've got the link that we can post in. If you haven't booked on there, it's essential that you book, but please do join us. It's a stakeholders event to say about where we've got with the project, and release the report as well ahead of that event. So do encourage as many people as possible to join and ask questions. We've got our official parliamentary reception next year on the 5th of February, but we're also very lucky next week to have a parliamentary reception for adult social care nurses, where Minister Kinnock is going to be speaking as well, and the initial reports are being printed and will be available there for members of the team. So I think there are some really exciting times to come, and we really appreciate you being part of this monthly group. Is there any other business at all? No. Fantastic. Well, I'll look forward to seeing you on the 9th of December. Thank you very much, everyone. Thank you.
Yeah, thank you.
Thank
Bye.
you. Bye bye.